Greetings, fellow peers, Madam Convener. My name is James Ivory and I'm a clinical nurse that works at Goldcoast University Hospital in the Specialist Medical Unit. Before I start on my assessment piece, I'd like to acknowledge that this assessment was done on a real consenting patient and their confidentiality will be maintained throughout this assessment. Hope you enjoy. So I have a 28-year-old female admitted to the Specialist Medical Unit with urinary discomfort from emergency. History of the presenting illness is that she had worsening fevers and she was feeling unwell over the weekend. She reported 2 episodes of hematuria and also reporting passing a small kidney stone. And she had also had increased urinary frequency with associated dysuria. On the day she came in, she had woken up in the morning feeling hot, febrile, diaphoretic, and having nausea and a headache. She currently denies any cough or upper respiratory tract infections. Currently, she has a fever, dysuria, increased urinary frequency, rigors, and feeling unwell. Moving on, I thought it would be essential to get a patient history from her, see what her background is. So past medical history is that she has a left horseshoe kidney and nil-voiced allergies. Past surgical history is that recently in February she had a left ureteric stent inserted for renal stones and a UTI. And social history, she currently works in tourism. Family history, there's a strong history of having kidney stones in both her parents and her sister. Father had history of prostate cancer, as well as her grandfather, and her auntie also had cervical cancer. So first and foremost, a set of vital signs were done because I wanted to get a baseline of knowing what her vital signs were. Respiratory rate of 20, oxygen saturations 96% on room air, blood pressure of 100/50, a heart rate of 80, and currently febrile at 39 degrees Celsius, and she's currently alert. Clinical significance from these vital signs is that her blood pressure currently is hypertensive, secondary to dehydration, and this is currently reflecting her hemodynamic status. However, there's no compensatory mechanisms currently because she's not tachycardic, and currently febrile of 39 degrees, and the presence of a temperature and rigors indicates a systemic inflammatory response that needs to be treated promptly. From the physical examination, doing a pain assessment is a subjective report and is the most reliable indicator of how much pain a patient is in. And the diagnosis of pain cannot be solely made on a physical examination, which means I can't just physically examine the patient without knowing how much pain she's in. And her reporting her own pain is the gold standard of pain assessment. So I thought I'd do the PQRC pain mnemonic tool, as it's a great tool for clinicians to remember steps in doing a pain assessment, and doing this information will lead to the origin of the patient's reported pain. So she's currently got localized left iliac fossa pain and left frank pain right here. And to get a good assessment to see if her kidneys are currently inflamed is that you do light percussion to the costovertebral angle just here. Kidneys are often difficult to palpitate due to the protective rib cage. However, if you do gentle percussion at this angle just here, can indicate pain which is from a distended or inflamed renal capsule. And she's currently got urge to urinate over the suprapubic region area. So the clinical significance of this physical assessment is that pain on palpitation is associated with either acute pyelonephritis and acute ureteral obstruction. Acute pain in the back also suggests an upper urinary tract infection, and flank pain is usually consistent with pyelonephritis or renal calculi. Pathology was initiated for this patient because it was essential to know what's going on with her path as such. So urinary blood cultures should be obtained with septic patients and treated with intravenous antibiotics. A urinalysis was used to evaluate for kidney stones, kidney infection, renal failure, or for screening patients with systemic disease. So she had a positive urine stick reviewing large leukocytes, large blood, and a specific gravity of 1.030. And she also had a urine MCS obtained because a urinary tract infection is currently suspected, which revealed more than 500 leukocytes, excessive of 500 erythrocytes. However, her epithelial cells are 40, which means, unfortunately, the urine was contaminated. She's had blood cultures, currently negative to date. A Chem 20 was obtained, and the only abnormal electrolyte out of the Chem 20 was a phosphate with slightly lower 0.71 millimoles per litre. A full blood count showed a hemoglobin of 111 and a white blood cell count of 13.1. A C-reactive protein was also obtained, which was 219. Urine culture sensitivities are important to identify the infective organism, which will help show which antibiotic needs to be used. A high white cell count infection is suggestive of a bacterial infection. The full blood count having elevated white blood cells is a sign of an inflammatory or infectious condition, and an elevated serum white blood cell count is inconsistent with pyelonephritis. Her Chem 20 reveals mild hypophosphatemia due to the serum phosphate being less than 0.75 millimoles. Blood cultures currently have grown no bacteria or microorganisms. And a CRP, a raised CRP, is indicative of an acute inflammatory phase and also an important marker for an early indicator of infection and sepsis. The medical imaging that was obtained for this patient was at a CT, kidney, ureter and bladder, and currently informed that her left ureteric stent that was placed in February is in good condition with nil hydronephrosis. However, pyelonephritis is a possibility with the urinalysis for clinical correlation, which has been done. If nil improvement has been done with the patient, a renal ultrasound should then be performed. So computed tomography scans are essential as it offers the best anatomic detail of the kidney, ureter and bladder. Patients with suspected pyelonephritis should have a CT KUB as it's used to assess for the presence of foci of pyelonephritis in the renal cortex. So with this patient, they were being treated for pyelonephritis and query a left ureteric stent. Health priorities for this patient is to first commence on a strict fluid balance chart, as it's indicated for patients who require strict fluid monitoring. Early signs of deterioration in acutely unwell patients can be detected by accurate fluid balance measurement and documentation. There was regular encouragement of peroral fluids. This increases intake of oral fluids to dilate the urine, reduce irritation to the inflamed bladder and urethral mucosa. Intravenous normal saline was given as prescribed because it's used to expand the blood plasma volume with hypertensive patients secondary to dehydration. And we were giving IV antibiotics as prescribed. She was initially commenced on gentamicin 4 times a day ampicillin. However, she wasn't responding to it for the first couple of days of treatment. So the medical team then switched over to broad spectrum piptazicillin due to the nil culture sensitivities available from the blood cultures or the urine. Leading up to the day of discharge for this patient, patient education is highly important. I was educating her that she needs oral hydration of 2,000 to 2,500 mils a day. This is to prevent further kidney stones, and this will help her keep her left ureteric stent patent by preventing urolithiasis. Oral hydration also dilutes the urine and, as I said, reduces irritation in inflamed bladder and mucosa of the urethra. And it was also important that she would be educated regarding taking her prescribed course of amoxicillin and clavulanic acid with food, and the importance of taking prescribed antibiotics with food to avoid gastrointestinal disturbance. The education of importance taking antibiotics as prescribed, as missed doses can cause lower therapeutic blood levels and the antibiotics will have reduced effectiveness. Regarding the evaluation of nursing care for this patient, is that I felt that regarding getting a clean midstream urine, is that you just don't get a urine MCS alone by asking a patient to do an MSU. What I felt that could have been done is that educating the patient on getting normal saline gauze or personal hygiene wipes to clean themselves before obtaining midstream urine. By doing this, I believe that we would have avoided getting epithelial cells on the urine. Therefore, we could have got a culture earlier on admission, then we could have treated with appropriate antibiotics that the bacteria is susceptible to. However, there were no further temperatures 24 hours since she was started on the piptazicillin, and she's now currently reporting much more improved compared to the day of admission. The patient was cleared by discharge by the treating urology team on oral antibiotics for 2 weeks. And the main thing was to educate patients to monitor for urinary symptoms and to represent to the hospital if there's any worsening pain, fevers, rigors, nausea and vomiting. I hope you enjoyed my presentation, and I hope I've been able to educate you on the physical inspection we should be doing on patients on a urinary assessment, and the imaging that should be done, and the pathology that we do for these patients. I look forward to hearing back from you guys on feedback on what I could do better in the future. But anyway, thank you very much.